Hello everyone, and welcome to my presentation. First of all, let me thank you all for coming here today. As you can see on the screen, the title of my research is Analysis of Stroke Assistance in COVID-19 Pandemic by Process Mining Techniques. Let me start by saying a few words about my own background. My name is Gabrielle, and I am PhD student in Health Technology at Pontifícia Universidade Católica do Paraná, in Brazil. My interests in research are process mining, data science, issues of health system interoperability, and health evaluation. This presentation is structured as academic writing following introduction, methodology, results, discussion, and conclusion. First of all, I'd like to give you an overview of stroke. Stroke is a non-communicable chronic disease that represents the second leading cause of mortality worldwide, including in Brazil, counting 5.5 million deaths in 2016. In stroke treatment, a therapeutical window represents the best moment to intervene in the pathological process of cerebral ischemia and minimize damage to the central nervous system. In most times, this window lasts only a few hours, which implicates the need for fast medical assistance for people who experience an acute stroke. One of the intervals in this therapeutic window is the onset-to-door time, representing the interval between the onset of stroke symptoms and the patient's hospitalization. The importance of early stroke medical assistance, since its onset, has been reported by several entities such as the European Stroke Council and the International Stroke Society. However, with the COVID-19 pandemic, drastic and rapid changes have affected daily the functioning of healthcare services, such as the suspension of programmed clinical activities during the lockdown period, significantly diminishing the search for emergency medical services due to fear of contracting the coronavirus, which resulted in the postponement of appropriate treatment for cerebrovascular diseases. Furthermore, in this period, assistance to stroke patients suffered negatively impacted worldwide, reflecting a sharp reduction in the number of hospitalizations for acute stroke and, consequently, in the number of patients receiving treatment within the therapeutic window. Therefore, the objective of this study was to identify the onset-to-door time through process mining techniques, considering the several paths within the healthcare network during the COVID-19 pandemic. Remembering that this analysis is relevant because recognizing signs and symptoms and the early calling of emergency services can change the outcome of stroke patients, reducing possible sequelae. Now, I am going to focus on the methodology. Brazilian Ethics and Research Committee approved this study through report number 4.917.962 dated August 19, 2021. We accomplished a retrospective cross-sectional study by analyzing event logs from electronic healthcare records of 221 stroke patients of a public hospital in Joinville, Santa Catarina, Brazil, from March 17, 2020 to August 21, 2020. The initial date of March 17, 2020 was chosen since it represents the start of the implementation of Santa Catarina's social distancing measures. The process mining methodology applied in this study is composed of 5 stages based on the Process Mining Manifesto. Stage 0 includes planning and justification, and in this research, it was presented in the introduction. Stage 1 embraces the data selection and extraction from the health information system. The dataset variables analyzed in Stage 1 were date and time of the first symptoms, date and time in which the patient sought help, where the assistance was requested, mode of transport to the stroke reference hospital, data and time of hospitalization, and the Rankin score of the patient at discharge. The modified Rankin scale, presented in the table, measures the degree of dependence in people's daily activities who have suffered a stroke. Its score varies between 0 and 6, in which 0 indicates the patient who had the least possible sequelae and 6 demonstrates the worst outcome, in this case, death. We grouped the modified ranking score according to the ranges 0 and 1, 2 and 3, 4 and 5, and 6 to simplify the presentation of results. In Stage 2, after the data extraction from the information system, data were pre-processed, excluding missing, incomplete, and undefined values in an Excel spreadsheet. Besides, the following variables were clustered: date and time of hospitalization and Rankin score after discharge. This was grouped to understand the relationship between a patient's possible paths and outcome. After, we used the DISCO toolkit from Fluxicon to discover the process model. A Excel file is input into the DISCO software, enabling the configuration of which columns are assigned to case ID, timestamps, and activity names. The DISCO miner combined fuzzy miner with process metrics and modeling strategies. Other process perspectives were analyzed in Stage 3, such as timestamps and resources. In this phase, a specialist knowledgeable on the stroke patient journey helped us understand the processes discovered and relevant findings. The models discovered in Stage 3 could then be used in Stage 4 for making interventions, predictions, and recommendations. The results of Stages 2 and 3 are presented in the next section of this presentation. Finally, I am going to present the results of this study. 2 main process models were discovered. These models represent the patient's path from the onset of symptoms to the moment of his admission to a public stroke reference institution. In the legends, the inverted triangle indicates the start of the flowchart, the rectangles represent the events, which vary in color according to the number of patients that transit through them. The lighter color indicates less patient and the reddish color indicates more patients transiting through that event. The arrows represent the path followed, which change in their width and color according to the intensity of patients transiting through that path. The numbers inside the rectangles or next to the arrows represent the number of cases, that is, the number of patients that went through that path, respectively. Finally, the square inside the red circle indicates the end of the flowchart. The first model presents events where the patient requested help from at home, public space, and nursing home. Already in the second model, the patient requested assistance and went to a non-reference public hospital and emergency care units after the onset of symptom. In Model 1, 142 cases were analyzed, which generated 568 events distributed into 11 activities. The mean onset-to-door time was 4.7 hours, and the median was 2 hours. Therefore, it is possible to conclude that the mean time between the onset of symptoms and the help request of patients that were at home was of 3.3 hours, whereas to get to the stroke reference service, 63% used mobile emergency medical services, 35% used a car, and the minority of them was transported via private ambulance. It was also analyzed that at discharge, 35% of the patients had rank in 0 to 1, 39% had rank in 2 to 3, 14% had rank in 4 to 5, and 12% died. The second model displays the flowchart of patients that, after experiencing the first stroke symptoms, sought help and were referred to public healthcare institutions other than the stroke reference hospital. In this model, 79 cases were analyzed and generated 316 events were distributed into 9 activities, making it feasible to display all the activities and routes followed by the patients until hospitalization. The mean onset-to-door time was 5.6 hours, and the median was 3.4 hours. It noted in Model 2 that among the public non-reference institutions for stroke, the most sought by the population was the emergency care unit, called UPA in this research, with 70% of the cases, and 30% went to the other 2 public hospitals. Furthermore, 9% of the patients at the emergency care unit and 48% at the public non-reference hospitals were not referred to the public stroke reference hospital via SAMU or fire service. Instead, they used their car. When relating the mode of transport to the patient's clinical outcome, a ranking of 0 to 1 is related to a mean interval of 2.2 hours via SAMU and 86 minutes viaduct private car. A ranking of 2 to 3 is associated with a mean interval of 3 hours viaduct SAMU and 5.5 hours via private car. Rankin of 4 to 5 with a mean interval of 2.1 hours via SAMU and 5.5 hours via private car. Rankin 6 with a mean interval of 91 minutes viaduct SAMU and 73 minutes viaduct private car. Now, I will discuss and conclude this research. Process mining has allowed the discovery and analysis of 2 process models. In the first, the onset-to-door mean time was 4.7 hours, and in the second, it was 5.6 hours. Although primarily, the onset-to-door time was maintained within the appropriate interval, it was identified that 36% of the population still sought non-reference institutions that increased the onset-to-door time, similar to the results found by Nguyen et al., 2021. In this research, the patient's mode of transport did not influence the onset-to-door time once in the majority of times, the patients were within the therapeutic window of 4.5 hours. However, some medical attendance was not within the therapeutic stroke window, either due to the failure to recognize stroke symptoms or seeking non-specialized service. Furthermore, although awareness campaigns are conducted annually to warn of the signs and symptoms of stroke, efforts are still needed to enforce the importance of and provide guidance for non-reference hospitals. Thus, considering the current scenario, Process mining has proven to be a valuable tool for assisting managers in more rapid identification of flows so that decision-making can happen in less time. Finally, I will available you the references used in this research. Thank you so much for your attention.